For a while, nobody was paying attention to pediatric HIV. Everyone was focused on prevention, and I think prevention has been very effective and very admirable to be or a very worthy cause to focus on prevention of new infections, but it doesn't change the fact that there are over 3 million children who still need treatment.
What we're all coming to realize is that there's this cohort, there's this group of older young people, 5, 6, 7, 8, 9, 10 years old, who are growing up living with this disease, and we don't actually have a lot of services that are particularly designed for them, and our data and our understanding around the epidemic is not good enough in these kids.
And by the time a child is 10, 12 years old, they are probably symptomatic. They may not be acutely ill, but we see the effects, for example, on the growth. Older children who have missed testing early on, who have been sick on and off, are not reaching their full growth potential. As you know, there's a huge treatment gap between access to treatment for adults against access for treatment among children. And in some countries, that gap is as large as, like twice as many adults are on treatment compared to children. In some places, 3 times as many adults are on treatment compared to children. So that's an injustice for me, to deny children treatment. And they are so vulnerable. A lot of them will lose their lives if we don't act and put them on treatment early enough.
I think the issue is it's not just one problem, it's a whole set of problems that happen together. So the issues that AIDS-affected children face in their lives are multiple, and they hit at the same time. There's high levels of stigma, high levels of hunger, high levels of abuse in the home, high levels of catching things like tuberculosis. And so when we think about improving their outcomes like adherence and HIV prevention, we're thinking about how to deal with a home life which is experiencing all of these issues.
A child with HIV usually comes from a family with HIV. What we know about families and parents with HIV, a lot of them face all of them face very difficult situations. They face a lot of stigma, they have ill health, sometimes they lose their jobs. So there's economic pressure, there's social pressure, there is the physical pressure of not feeling well and taking care of yourself. So a family is facing all of that, and then now they have a child also with HIV. So how do they manage to take care of a child while they're having all of these other issues?
We had to rely on their caregivers. And relying on caregivers means that today you could get a good caregiver today, tomorrow you may get a nonchalant caregiver.
The orphans are the children who have multiple caregivers. I come today with a child, next month somebody else comes, next month another person comes. So there is breakage of communication when you change the care providers.
You can find a child who has been on treatment for a long time, and because there's no support, this caregiver changing, you find that you lose that child.
I believe that we can talk about the end of pediatric HIV. I think actually that should be our common focus, our common goal. Whether you're a facility in the DRC, that is really struggling with resources, or whether you're in a better resource facility in Rwanda that is delivering exceptional results.
There's a lot of movement now, a lot of interest in ensuring that all children have access to treatment. So I think this is a good time for us to be able to focus on this, but also to be able to articulate what are the real needs on the ground, to make sure that all the global movement and the interest that's there around pediatric HIV actually translates into something that's effective on the ground.
Importantly, we need to be realistic. Everybody's context is different. There will be health facilities who have more resources and access to support than others. We need to look in our own context and say, what can we do in our individual capacity and within our clinics to make services more appropriate, accessible, effective for young people?
We need to go to the community, because whereas we can get a few of the children who come to the health facilities, what about those who don't come? What about those whose mothers don't come?
If we don't look beyond the clinic, we're not going to solve the problems of adherence and prevention.
Imagine if we went out and tested children of parents that are already in care, we could potentially actually identify a lot of children that are living with HIV and put them on treatment.
Our job as an organization and a network is to support the front line in accessing those children. And sitting in a clinic and waiting for patients to present themselves, waiting for caregivers to bring their young children in, waiting for adolescents to come into the clinic might not cut it. We are looking with our network and clinic healthcare providers at ways of using multiple entry points to find those children. And those entry points might be schools, and there might be orphans and vulnerable children platforms, and there might be other components of the health sector.
And so how do we expand testing to reach orphans and vulnerable children? Some of them are in institutions, and it's not conceivable or practical that all of them would descend on a healthcare facility for testing. So we need to take out testing and target early childhood development programs or other places where we can find OVCs and offer them testing.
We in the health sector aren't going to provide all the solutions for these children. And so we should be able to link up with other sectors. There may be feeding programs within the community, or there may be other resources within the community that these children need. And so how do we link up to other social services within the community?
And I would say look to the communities and to the families that these children belong to. Help empower those parents, help empower those communities to deal with the barriers that they're facing. We as health workers, we can't solve all those problems. We see the impact of them, but we need to connect with the leaders in the community. We need to engage the community in conversation, and we need to be very supportive of the caretakers of children with HIV.
The success over the years, I can say, has been to identify what is this that we can do to solve the problems based on the situation we have. For instance, the fact that sometimes the primary caregiver is not there or is not able does not mean that there is nobody else in the community who can support the child. So we've really been active in identifying who else is a caregiver.
We can't just see treating patients as a clinical intervention, that we need to understand that children, adolescents, young people and their families exist in many different contexts. And we need to be more responsive to those contexts and appreciative of people's different realities.
The crux of the issue is the caregiver and the empowerment of the caregiver, the knowledge of the caregiver.
So there are a lot of things that I've seen people do to help families. Some of the simpler ones are to set up the healthcare center to address the needs of the family. So if you have 3 people in a family with HIV, let them come together for their visits to get their medicine. Don't make each one travel individually. Help them learn to support each other. One thing I'm really advocating now is that we set up special groups for parents of children with HIV to talk about how to deal with the challenges they face as parents in giving the child the treatment, keeping them in school, doing all the things that we need to do as parents.
It is not the end of the world. And if you have hopes in your dreams for the future, you achieve it.
PATA is actually working to make care better for children right where they receive services, strengthening the capacity of the nurses, strengthening the capacity of the doctors and the counselors and the team as such.
It's one of the only organizations that really represents the reality on the ground. There are very few organizations that can effectively do that.
It's really around best practice sharing. It's also feeling like you're not alone, like other people face the same challenges as yourself. And but really, I think also it's a sense of community in terms of people feeling like they all have a common cause in which they're united and fighting and working together in.
It brings together practitioners with academics, with policymakers, and was really aimed at supporting practitioners in improving and ongoing learning. I think that's really special.
So when we meet with PATA, we are sharing the information. And every time I leave PATA, I go back home with something new that I'll go and implement. So it has matured the clinic. We are now at a better level from where we started.